Thank you, Audrey. This meeting is being recorded. The recording will be posted on the Cost Board's webpage shortly after today's meeting. TBW, who I see is on today, may also be streaming this meeting live and archiving it for additional viewing opportunities. We have a full agenda today, and this is a 3-hour meeting. So typically it was 2, so this goes until 5, so a little longer than normal. We have built in a break for folks, as I'm sure folks will need that. And without further ado, I will hand it to Michelle Needham. No problems.
I think we got it.
All righty, let me do a sound check. Can the people online hear me with our little microphone? Excellent. Thank you so much. Thank you, Ross, for getting us started. I think with that, I'll call the meeting to order and get to my notes to know what I'm supposed to be saying. All right, as you noted, it's a little extra long meeting today. We have some nice topics, beginning overview on some of the recent passage of the federal reconciliation bill. We have a couple of conversations about that from Ingrid Ulrey at the Health Benefit Exchange. I believe Jane Beyer from OIC is going to contribute to that discussion. Evan Klein from Healthcare Authority will do an overview of our HCA impacts as well. And we have a different presentation from Mandy Starr at OFM, who will talk about the state health plan as part of our policy levers and other activity that are happening locally. We have some scheduling issues, so we do have some of those going back and forth just to accommodate people's busy schedules this time of year. So we will have a lively conversation and then round out some of that impact conversation at the end of the meeting with a facilitated panel discussion from our board members and their colleagues. I think with that, we can begin roll call. I'll turn that over to Ross.
Thank you, Michelle. I'll start roll call now. I'll call out the member's name if you could say present. Jane Beyer. Thank you. Eileen Cody. Thank you. Louise Cook.
Present.
Lois, I am so sorry.
No
Lois,
worries.
thank you. Bianca Frogner. Bianca Frogner. I'll note is absent, although we have talked to Bianca and we expect her to be here later.
Okay.
Oh.
See her name. So I think she's with us, maybe not.
Okay, I will check back at the end. Ken Gardner.
Here.
Thank you, Ken. Jody Joyce.
Present.
Thank you, Jody. Greg Marchand. Greg Marchand. Marking Greg as absent. Mark Siegel. Mark Siegel. Marking Mark as absent. Margaret Stanley.
Present.
Thank you, Margaret. Ingrid Ulrey.
Present.
Thank you, Ingrid. Kim Wallace.
Present.
Thank you, Kim. Carol Wilms. Carol Wilms. And marking Carol as absent. And I realized I failed to do this in the past. Michelle Needham. Present. Okay. Thank you. So we have a quorum present today. I'll now hand it over to Michelle for the next item on our agenda, which is reviewing the June meeting minutes.
Microphone. Thank you, Ross. I believe we're in tab 2 of the book. We have the June meeting minutes and they're shared on the screen as well. Yes. And I will, as normal process, we'll use consensus vote to approve the meeting minutes. Is there a discussion of the June notes at this point? Seeing none, is there a motion to approve the June meeting minutes?
So moved.
Second. Meeting in second. Thank you. All right, all in favor, say aye.
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 All opposed? Hearing none, minutes are approved. Great. Thank you. All right, we will hand it back to you, Ross, for an overview of public comment.
Thank you, Michelle. We'll begin the public comment portion. If you turn to tab 3 of your packet, you'll see one public comment, and I just want to make an announcement. I failed to include public comment that we received from Washington State Hospital or Medical Association. Apologies. That comment is now included in the packet available online. It will say an amended meeting packet, and that may be posted immediately after this meeting if it's not available during the meeting. And again, my apologies, and we will include WISMA's comment in the next meeting packet as well, and we'll invite Jeb or anyone from WISMA if they'd like to speak to that. Again, my apologies. Just briefly on written comments, we allow individuals to sign up to provide public comment before the meeting, and we start with those that have signed up in advance. If you've not signed up and would like to provide public comment, please raise your hand. Then I'll call on you, and after we hear from individuals who have signed up, you'll have an opportunity to speak. When you're called upon, please state your name and affiliation, if any, before speaking. As noted at the beginning, you'll be sent invitation to become a panelist. In order to turn on your camera and provide audio for the public comments, please accept that panelist link. It may take a moment, but you will be converted over to a panelist. Given the number of public comments at our meeting today, we're going to have a 2-minute limit, and there'll be a timer up on the screen. You're also welcome to provide comments in writing via email at any time, and we will put the email address for the cost board mailbox in the chat. So with that, I will start with hca and Katerina LaMarche, I believe, is speaking to those comments, and happy to let them speak. And apologies, Katerina, if you're not here, if there's anyone else from hca that would like to speak to the comment, happy to give you a few minutes to speak to that.
It'll take just 1 second, Ross. I just gave her permission to talk, and I know sometimes there's a delay.
Sure. Thank you, Rochelle.
Yep.
Welcome to Rochelle Bogue, the cost board manager who returned from maternity leave. Very excited to have her back. So thank you, Rochelle.
Well, we pause. I'll just note for the record that Bianca is with us online. She's present.
Hi, I'm here now. Sorry, thanks for the opportunity to speak. I actually hadn't prepared public comment for this, but if I have the opportunity, I'll just present. We submitted a letter that's included within your materials that touches back on taking a deeper look at the methodology and the data collection process, because we really want to underscore the importance of having data that's actually usable for providers so that they can make changes to reduce their costs. And there's a specific list of updates that we've cited that would help improve that process. And then also taking another look at the benchmark. We do have a lot of concerns about the rates, especially in consideration of the cuts that are being made at the federal level and the impact that that's going to have on hospitals in Washington State. So would appreciate your close consideration to those things, and hopefully we can make improvements to ensure that providers can meet the benchmark and that the benchmark is reasonable. Thanks so much.
Thank you, Katerina. And I will see if Jeb Shepard or anyone from WISMA would like to speak to their comment. Again, apologies that I failed to include that in this packet, but wanted to give an opportunity to speak to that if they would like.
Yeah, can you hear me, Ross?
Yes, I can. Please go ahead, Jeb.
That was fast. No, thank you for commenting on the letter that we submitted. They are suggestions as we near the second round of reports in the late summer or fall, I believe. Some suggestions we had from our members that received the reports last year around how to make them more actionable. And so take a look at that. Appreciate it being included in a supplemental packet and in next month's packet. And we are very happy to meet and discuss our recommendations. Thank you very much.
Thank you so much, Jeb, and thank you for your understanding on that. And now I'll open it up to anyone who has their hand raised who'd like to provide public comment today. I'm not seeing any hands yet. I'll give it another moment. We encourage folks, if you have any public comment, to feel free to share. Okay. Well, I won't belabor that. Again, we always welcome written comments either to our board inbox or to any of staff inboxes, and we will direct those to Cost Board. Thank you again for your public comments. We appreciate them and value your comments. Next, we will hear from Advisory Committee Chairs Eileen Cody and Bianca Frogner, who will provide an update on the committee feedback and tie into the Cost Board work going forward. And I'll pass it to Eileen and Bianca. Thank you.
Thanks, Russ. And we actually haven't met since March, but we had met March 27th, and this is a summary. We didn't get a chance to actually talk about it at the last board meeting. So it's a carryover. We went to both of the advisory groups and with a set of questions. We could move on to the questions so people can see them. We had very good discussion about these. I think that really having some interaction with the committee members to find out what they thought we could do to improve and make sure that they felt like their input was being heard. So as you can see, the different questions that we had discussed with them, I won't go through and read each one, but especially making good use of your time is something that we want to make sure that everybody feels like they're not wasting their time in dealing with us. So we went through that, and you can move to the next one, the feedback. And that, as not surprisingly, they thought that they could be utilized better than what we have been doing, and that we should focus our questions coming from the board to the advisory committees as to what is it we're expecting from them. They didn't feel like they had gotten clear direction from us. We also talked about we have had the data and the stakeholder meetings being done together, and so next year we're going to make sure that they're divided, because that was another. At sometimes they said it was appropriate some of the times to be meeting together, but at other times they felt like they should be meeting apart. So that was definitely good feedback to get from them. And then I think that definitely there had been some frustration about the guest speakers and data presentations that they had received, not really understanding how it was connecting to the cost board's work and why they were getting this, and really didn't see how it was going to basically bring down the cost of healthcare. I think that I'll just summarize it that way. So there was a lot of discussion about that. And then, of course, data issues, and Bianca will talk about this, but the committee wanted to make sure that we were optimizing the data that we receive, and that we make sure we know what the data is and is available for us. I'll get it said yet. And then they would like increased email communication between meetings, but from staff and the board to the advisory committees. And of course, that's changed even more since March, the reflecting on the changing healthcare landscape, and which is only going to make all of our jobs a little bit harder. I think I'll phrase it that way. But that was some of the discussion that we had. Bianca, do you want to add anything from this feedback?
Yeah, thanks for that summary, Eileen, and hopefully you can all hear me. I'm sorry earlier for my technical difficulties, but I am here. Yeah, it was a great discussion. I think, we have great folks who are on these committees, so they really do want to be able to contribute their expertise there's kind of different dynamics on each of the committees. And I think the data group really wants to be used for their data expertise. They seem to, some of them are offering up their data. So try and figure out how to engage them more in that way is good. I think there is a lot of time that we're needing to bring people together, in part because we're summarizing or sharing back to them similar information. And so I think there's sometimes it makes sense to come together, but each group certainly has, I think, a desire to kind of be utilized in the best way that they were appointed here to be utilized. And so I think that's what we're kind of grappling with. And maybe with that, I can move on to the next section, maybe just to give a little bit more specificity too on how this kind of, some of the discussions that came out of this part about the hospital expenditures discussion. So I'll go to the next slide here. So we summarized, so this is a summary of the presentation that we gave to this joint group where we reviewed data on hospital spending, which I believe this cost board also saw, and showed hospital inpatient and outpatient spending, and showing that those are the primary drivers of cost growth in Washington state. And then we discussed several strategies, which I'll kind of show and highlight and remind people what those strategies are on the next slide. And then we had a facilitated discussion on cost containment strategies and getting input from the advisory committee members. So next slide. So after presenting some of the trends in hospital spending, then we gave these strategies that were also shared here with the board to get the input from our joint committees here. And so 3 broad categories of strategies included tying cost growth benchmarks to specific values, have some independent but complementary actions, and have some combination of independent aspects versus tying cost growth to specific benchmarks. So we presented these strategies to have a discussion, and go on to the next slide. The feedback generally from the committees, as we discussed, was that there's 2 kind of sets of comments that kind of came out of here. One was this question about whether hospitals can really mitigate cost growth given the convergence of economic and policy changes that are happening right now. And then the other kind of vein of conversation that came about was whether controlling hospital pricing is the right strategy for the cost board to focus on. So next slide. There was a discussion about some of the unintended consequences by kind of focusing on this conversation and these sets of strategies. One is that there could be some negative impacts to hospitals' financial stability, particularly their inability to continue operations if we kept kind of focusing on this line of discussion. There was a concern that some of these strategies may lead to some incentives to avoid treating certain patients who may be the drivers behind some of the high costs. And then there were concerns expressed about the negative impacts of treatment quality if hospitals could not actually afford high cost drugs or technologies or devices to otherwise help support patients. So we'll go to the next slide. So the committee had some suggestions on maybe what the cost board should consider as we move forward. One is to prioritize Washington state data versus national data so we can have more informed discussions about what are the right strategies based on Washington state data. There was a question about whether we can learn from some of the hospitals within Washington states who have lower costs to figure out what is working well. And then another area, a suggested area of work is whether there could be more attention to how we can help hospitals make changes to their pricing and costs. Because there is a concern that maybe they don't have as much control as what may be otherwise indicated in some of these conversations. I don't know if there's another slide. I forgot now. Oh yeah, okay. Some additional ideas that came up. These were kind of a smattering of topics that came up during the discussion. One was a question whether or not data could be analyzed by cost, whether we can analyze cost by specific conditions and service lines. We've done some of that work before, but I think there's a desire for more of that information. I think there's a desire to incorporate information about quality and health outcomes and patient access alongside spending data. There were some questions about how Washington's guardianship laws may be affecting hospital finances. And there was a desire to maybe look more at the supply side of what hospital costs, what hospitals may be incurring in cost, including hospital infrastructure, wages, the increasing cost of drugs and equipment, and generally overall inflation rates. And then there was a desire also to maybe look at some of the drivers of avoidable emissions. So these were more data-driven kind of suggestions that were brought up by the group. So with that, I think that's the last. Yeah, so that's kind of where we landed with those with that last meeting. I don't know if we wanted to, if Eileen,
board
if you
have
had
any-
other additional comments or thoughts on that conversation that we had.
Oh, I just thought that if any of the board have questions for us, we'll try and figure out whether we have an answer. Lois?
I just don't understand or am curious what the impacts of Washington guardianship laws can be. What kind of area is that you're talking about, or?
I actually can give you an example of that.
Okay.
Because I know Harborview's had troubles with this, where like some of the homeless population come in, they can't find next of kin. I know the nurses at Harborview have even gotten on to ancestry.com trying to match things with the patients. And at least in the past, that's been a few years ago that I heard those stories, but there's steps. We've updated it a little, the legislature has updated it a little bit, but there's still work that could be done. It takes a long time and it's very expensive for people that are like on a ventilator, and really there's not hope, and there's nobody to make the decision till a guardian gets appointed.
Okay, thank you.
Jane?
So on the suggestion related to trying to take a look at sort of lower cost hospitals, we have the work that John Bartholomew and Tom Nash did, and I think they did put hospitals into different buckets around cost margin. So, or the peer grouping. So it seems like we do have data if we wanted to have some discussions with some of those hospitals about how they manage costs. I'm trying to think of where we already have information that's been presented to the board that can be repurposed.
Yeah, I think Jane, I think you kind of got to the point, which is that they want to, once we identify which are those low cost hospitals, is to hear like what's working, right? So that's the step that I think maybe has not been pulled out as much.
Great. Seeing any other hands up at the moment? Just do one more call. Not seeing any. All right. So thank you both, Eileen and Bianca, for co-chairing that both those committees and bringing the summary of that just really helpful discussion. I think good food for thought for all of us as we start our planning for 2026. And I know the staff team is already designing their 2026 calendar and meeting opportunities. So we'll take that into consideration. All righty. I think we're into tab 5 next. And we were just going to do a very brief visual chart here on the what I'm calling the multifaceted approach for the board discussions. Again, this is probably just a summary of the way we've talked about the work. Go ahead to the next slide, please. Where the current work, the foundational work of the board that the legislature has established for us is around the data-focused measurement and monitoring growth and the performance against the benchmark, as well as looking at those cost trends and what is behind each of those cost trends. So that annual deliverable on cost drivers, the annual deliverable on the benchmark performance, and some other data-driven work streams that inform the strategies that we might begin to explore with the board or have already begun with the board to focus on containing costs. So that's that green piece of pie. And really, I would argue that's probably 2/3 of the pie at this point because of the size of the team that we have and the limited resources we have to dive into some other opportunities. But we've shown some of the other, again, multifaceted strategies that the board can begin to examine once we've built on that foundation of annual examination of data, that will look at those strategies that address growth. Some of them we have in motion. So trying to show that the legislature has passed a few foundational pieces for us, including the bill that was passed this year on reference pricing that will give some different tools for us to explore with modifying costs, some foundational tools with the legislation that informed the state health plan. Mandy Starr is going to give us an overview of that work today. There was a health plan registry passed. Again, that's foundational information that will inform opportunities into the future. Some continuing discussions that we believe the legislature will explore and that we think are key to this body's work as we move forward are that continuing market oversight conversations, or what we're calling Keep Our Care Act in this state, but we had several different bills around trying to contain market pressures and private purchase of public entities, some things like that. So we believe those conversations will continue, as well as other boards and entities that connect to this, such as Eileen's other board that she serves on for us, the Prescription Drug Affordability Board, some of the work that's underway over there. And then we have, of course, the new areas of at risk that we're going to talk about as well today with the federal legislation that was passed and some other threats that are top of mind for many of us. So that was just a quick glance to sort of frame where we think all the strategies fit in the big pie of the board's work and how we have to keep balancing those as we go forward. So that wasn't to belabor a visual, but more just to keep us grounded as we plan into the future, that we're tackling those different pieces. I think with that, we can move into the next overview presentation that really begins an introduction of the federal reconciliation bill and the impacts on the health marketplace. In particular, we'll start with that and the insurance marketplace reactions from both Ingrid and Jane, and then later in the afternoon, we'll have a discussion on healthcare authorities' impacts. So with that, Ingrid, would you like to begin?
Yes, happy to. Michelle, can you hear me okay? All right, thank you. I'm really sorry not to be there in person, and I just want to say I really appreciate the structure of the agenda today and the level of conversation. I think it's just to point out the obvious, we're just in such unprecedented times. So I think it is very appropriate to focus some time at this meeting on the significant federal policy changes that we are now seeing. So my focus of my comments will be on the impacts of these changes for the marketplace side of the work. And before I do that, I just want to remind everyone that the Health Benefit Exchange, and specifically our platform, Health Plan Finder, we're the front door, also not only for people shopping in the individual market for a qualified health plan, but also for the non-Magi or the regular Medicaid program, excluding at this time classic Medicaid. So in addition to everything I'm saying, we'll be working in close partnership with you, HCA, DSHS, and others on implementation of the Medicaid provisions in HR 1 specifically. So with that, I'll skip to the next slide. You're all seeing. Oh, no, sorry, back one. You see, is everyone seeing a three-legged stool? I only see one person in the.
We do have
I
your
probably could
stool.
make a. Okay,
You
the
got
person
it.
I think nodded. Is that you, Ross? Okay. I hate being virtual. I really wish I was there with you guys. Okay. Um, so a couple things about impact on the marketplace is we're really seeing the combined impact of two things and awaiting another. So three legs of the stool will impact Washingtonians' ability to gain access to health coverage through Health Plan Finder. One is a CMS market program integrity rule, which was issued in June of 2025, which I'll talk about more in a minute. The second is HR1 reconciliation package signed by the President, 4th of July, 2025. And then the third that we are anticipating, is the scheduled expiration of the enhanced premium tax credits, which have been in place since COVID times and are truly driving affordability in a robust way. So I'm going to share in a minute what the scary figures that you see in the box next to the three-legged stool. But let me just point out first that this data that I'm sharing is really assuming for these three things combined, the worst case scenario. And this data on outcomes does not account for major mitigation efforts underway in our state, essentially to achieve harm reduction of these policies for Washingtonians. So I will be talking about what those are, but know that this assumes full and complete implementation of the two things that have already landed, the rule and the bill, as well as the expiration of the enhanced premium tax credit. So altogether, from those three vehicles, I am concerned that the current enrollment in the exchange, which is currently approximately 280,000 individuals, I'm concerned that our market will be reduced by a third to a half. So this enrollment drop won't happen right away, and many of the effective provisions here we're talking about are scheduled to be effective over time. But over time, this could really lead to significant reduction in the number of folks who fall through the cracks of other covered systems and come into our market to get covered. The premium increase impacts could be up to 15%. There's a lot more to unpack there, and Jane, I'm sure you'll speak to that as well. And then, of course, the ripple effect across the entire healthcare system as more people become uninsured, but continue to seek care. And that's in the form of increased pressure on uncompensated care for hospitals and other parts of the healthcare system, which estimated 100 million plus. So this is the overall effect. Keep in mind that for each of the three legs of the stool, there are overlapping impacts. So the same individual could feel a negative impact from these three things and drop coverage. And when you see the numbers, you will see that they add up more to the total combined impact. And that's because of the overlapping nature of the impacts. The other thing I would point out is that these three things are the three current waves of federal policy change that are landing now. And there will be more. We anticipate more. We know that there is likely to be another CMS rule around the corner, and there is some discussion of another reconciliation bill that might want some members of Congress want to attend to some things that were not included in HR1 due to the parliamentarian rulings. So that's the overall message. And I want to say the theme here is all three of these policies basically do three things. One is they restrict eligibility, who can shop on the market, who can qualify for advanced premium tax credits. Secondly, they increase prices for our customers, overall costs, and they add a lot of red tape. They have the impact of making it harder to get covered and harder to stay covered. And much of this is under the umbrella messaging of the need to address fraud, waste, and abuse in the marketplaces around the nation. And I want to be clear for this audience that we have very high program integrity here at the Washington State Benefit Exchange, as well as do other state-based exchanges where we put in place safeguards and many mechanisms to prevent unauthorized enrollments, dual enrollments, And that is not the same for the federally facilitated marketplace. But that is the rationale that's being put out there as to the reason for these changes. So next slide, and just know that I only have a few slides. So even though I talked at length to that one slide, I'll go quicker now. Unpacking them one at a time, the three legs of the stool. So the CMS rule includes many different provisions around reducing the open enrollment period, affordability and benefit changes, restrictions on eligibility. The headline here to know is that our Attorney General, Nick Brown, as well as combined with 19 other, a total of 19 states, have taken legal action, filed suit, and currently we anticipate that we will be under a preliminary injunction and halted from having to implement this rule. So we're very grateful to Attorney General Nick Brown's leadership. And that means that the estimated impacts that you see in the box on the side, at least for now, while this is halted and contested, would not occur. So next slide, please. Regarding HR 1, there's so many provisions in there that will impact the marketplace. This slide includes some of the headlines. In the first plan year 2026, so this open enrollment for our exchange, there's really only one major provision that we're needing to make system changes now to implement, and that is restricting the definition of who qualifies as a lawfully present non-citizen, currently who do have access to advanced premium tax credits, but going forward will not. So we're implementing that, even though we don't agree with it, but to be in compliance. And you will see other provisions in this slide that we would need to implement over time by the effective dates. The one provision I call the killer provision, we have some runway to prepare for and to plan for some mitigation. It's called pre-enrollment verification. And what it would do was significantly limit or disallow how we do what's called conditional eligibility, assuming that based on data sources, people are eligible as we check any data inconsistencies to double check that, as well as auto renewal, which enables us to renew customers to easily renew and sign back up for the plan that they are currently in this plan year and have it continue in the next. So you can see in the box that if all these provisions are implemented per the schedule, it contributes significantly to the bigger enrollment reduction that I headlined with, as well as contributing to premium increases. So next slide. So those two things I talked about are things that have already landed, that we're already analyzing and addressing implementation issues with. The third thing is the scheduled expiration of the enhanced premium tax credits. That's scheduled to happen, it is scheduled to expire by the end of this calendar year. Congress will be taking this up. We know there's a lot of discussion when they return from the August recess. There is a potential that they could decide, instead of letting it expire, to extend it. A lot of discussion there, and I think our planning assumption is that it will expire. However, we are hearing a lot of understanding and interest from members of Congress about how severely our customers would be impacted if it goes away. In the box, you can see the headline there. Our actuaries predict that if this expires, prices on our market would increase so significantly, an average of 65% across all of our customers, and differently depending on each individual situation, that 80,000 of our 280,000 customers would deem their insurance to be just too expensive. They couldn't afford it and would drop. So that's a really big, significant impact that, of course, would contribute to that bigger headline about the ripple effects across the entire system if 80,000 additional Washingtonians were to become uninsured. So I think I covered my slides. Does anyone see a next slide? Because I don't. Oh, okay, great. So I just want to thank everyone for your interest in hearing about how these different layers of federal policy change could impact the exchange market. And we're really appreciative of the partnership of all the stakeholders in our state, as well as our colleagues and peers in the 20 other states who have state-based marketplaces, working together to think, to pivot, and to think about how we can implement and be strategic in a way that mitigates harm for customers who rely on this market. So that's what I have, and I'll turn it back to folks in the room.
Thank you, Ingrid. It was a very nice set of discussions to overlay the marketplace impacts. I see Eileen has a question.
So Ingrid, the money that the state has put in to reduce premiums also, I know they didn't cut that completely this year, right?
Yeah, thanks for asking about that. Yeah, let me get your question.
Well, so my question is, I assume then that the exchange board will review and change how those subsidies go instead of just, and decide what's the right way to try and if the other subsidy, the tax credits disappear. That's my question, is how much mitigation? Because I mean, I don't see that legislature is going to find any more money to give you. Things don't look that good. So I'm just, have you had discussions already about how you would change that? I guess is what I'm trying to get at. And the other thing I would just say is I feel like the cost board that we really have to look at this. It's dire times. It's, I'm not very happy about the way things have gone, but we should also look at it as this is when we have to really do our work to try and bring down the cost of healthcare so that maybe more people can afford it. And we don't have as many uninsured and because like for the hospitals, a little bit of money is better than no money. So just trying to look at things in that regard.
Eileen, thank you for bringing it back to the mission of the cost board, and I appreciate that. And there is definitely a strong connection here of driving affordability, so that we can enable people who have insurance to afford care, as well as to reduce the driver of that increases cost of people accessing care who are uncovered entirely. And in terms of Cascade Care Savings, so that's the state premium assistance. Really appreciate you raising it. It's really tough state fiscal crisis. And in that context, we're really grateful that the legislature did extend the general fund appropriation for Cascade Care Savings by 1 year. So in this one pivotal year of 2026, we will continue to have Cascade Care Savings for our customers. And then we will be coming back in the supplemental session to request a continued extension of the program. There's absolutely no way that state premium assistance will backfill completely, or even, in a large way, fill the gap left by the loss of the federal enhanced premium tax credit, which equates to a total of $285 million in federal funds. However, especially for our lowest income customers, because only those who are at 250% of the federal poverty level or below, that's the eligibility criteria for Cascade Care Savings. Those folks, it's an extra layer of support and protection that could keep them covered and is increasingly important in this context. And each year we assess what the appropriation is and how it's allocated. And our board, supported by our staff, will continue to do that over time as we continue, assuming we continue to have access to this important state support.
Great. Jane, I think you were going to add some comments around the insurance market broadly.
Yep. Thanks, Ingrid, for that sobering information. So I wanted to sort of step back and put this into the context of the role of the Office of the Insurance Commissioner in all of this is health insurers submit their proposed individual market and small group market rates to us in May. So we received those on May 15th. And then in order to make sure, and we have a team of actuaries that are reviewing those rates that go back and forth with the insurance companies all the time to try to get to what the right and justifiable rate is for individual and small group health plans. And in order for Ingrid and her team to be able to get all that information loaded into the health plan finder and be ready for open enrollment for next calendar year, OIC needs to finish our review of the individual market rates on September 4th. So let's think about all this, right? We ask the insurance companies to submit rates to us that assume that the enhanced advanced premium tax credits go away. And there were a range of premium impacts that were submitted to us up to about 6%, contributing to up to about 6% of the rate increase. When those rates were submitted, the marketplace integrity rule that Ingrid just talked to you about had not been finalized, and the budget reconciliation bill had not been enacted by Congress. So two big changes that impact the upcoming plan year, so calendar year 2026. And Ingrid mentioned that there was a lawsuit filed by about 20 states. Washington State is one of them. The final rules go into effect on August 25th. So the lawsuit was filed July 14th. There's been a request to the court to issue what's called a preliminary injunction to stop all or part of the implementation of the rule. We may not know, we don't know when that preliminary injunction motion's been scheduled. We don't know how the court is going to rule. And it could be a very last minute thing. I mean, we didn't know on August 24th whether that rule is implemented in Washington State. So if you think about all of our uncertainty, think about it from the perspective of the health insurers. That's a lot of uncertainty to have to deal with. One of the provisions in that marketplace integrity rule prohibit states from including gender affirming care in our base benefit package. Washington State is one of the states that does include that. And there's a complex law that basically says that if, as the legislature has directed, people are going to continue to have access to those services, the state needs to pay the cost of that benefit. It's called defrayal. And so we, in due diligence, actually just last week sent out a request to all of the health insurers to say, go back in, look at all of your claims for this care as it's defined in the rule, and let us know how much you're spending. We greatly appreciate the fact that the legislature in the budget for 2026 funded the cost of our defraying the cost of those services. So for plan year 26, if we have to implement it, we're good. We have to go back to the legislature next session to have discussions about defrayal out beyond that. And Eileen knows this. We went through a period in the late 1990s when the individual market went into basically failed. And while the situation is certainly not as dire as it was back then, the one thing to think about is when Ingrid presented those figures about losing 35 to 50% of enrollment on the individual market, let's think about it, right? If it's a big administrative hassle to verify my income, if it's a big administrative hassle to make sure that I filed my income taxes, even though I may not even have to because my income is so low, and then I have to do the reconciliation, et cetera, et cetera, et cetera. What we all fear, and what the CBO basically said in their analysis of the budget reconciliation bill, and in what the federal government actually said in the marketplace integrity rule, is that the people who are most likely to say, this is just too big a hassle, I can't deal with it, are younger, healthier people. And we all know that the premiums that we pay are a product of two things: the amount of services that are used and the price that is paid for the service. And the sicker and older the folks getting coverage in the individual market are, the more services are utilized. And so what we always are conscious of, especially with the expiration of the enhanced advanced premium tax credits, is at what point are those younger and sicker people just going to say, I can't afford this anymore? And so that raises concerns that we had lots of discussions about in the late 90s and the early 2000s about the stability of the individual market. So that's sort of the bigger picture that we're looking at all of these changes in. So I think happy to take any questions.
Jane, on that happy note, I just want to
Apologize.
can you hear me okay?
Yep.
Yeah. Oh, I think I'm really worried about some of our peers as state-based exchanges in states that are currently serving 100,000 customers or less. And Jane, what you pointed out of the risk pool issue, as they get really, really small, it gets harder and harder and the prices go higher and higher. I know that for us, we are working diligently and tenaciously on a range of mitigation proposals, mitigation strategies, and harm reduction, including very grateful to Commissioner Cooter, Jane, for the emergency rule around silver loading, or what's known as premium alignment. We will find creative ways to do everything we can to keep our plans affordable and accessible to Washingtonians. And we know that in taking a large reduction in our number of enrollees, we will still be able to keep the lights on and keep our market functioning. It just will be a lot harder. So I appreciate this honest conversation and just sharing with all of you what we see, and then thinking about the impacts on the broader healthcare system and on the mission of this board to contain healthcare costs. So just wanted to conclude with that and let people know that we will still be here. We will keep our lights on, and we appreciate all the support from all the stakeholders, concerned as we are.
And I mean, Ingrid's right. We're going to do everything we can within our authority to keep the market stable. But it's a reality that we all want to give a lot of really serious thought to.
Yeah, thank you, Ingrid and Jade. I think we'll build on this conversation as we continue the overview of the Healthcare Authority program impacts and the rippling impacts that will have on the delivery system as well, and our Washington residents and their options for coverage at all, much less affordable coverage. So we will be continuing the doom and gloom this afternoon, or, opening our eyes to all of the impacts that we will think creatively about. Before we continue that conversation on the Healthcare Authority Medicaid impacts in particular, we will have a happier topic. We'll shift gears here and think about strategies going forward that help the state with some foundational information. And I believe I saw Mandy Starr online with us already. So she is teed up to begin talking about one of the bills that passed this legislative session. Mandy, do you want to kickstart the conversation? And maybe I should give your whole title. Let me see if I can find your whole title so I can say that appropriately. No, I have it. I'm pretty sure it's on the agenda. All right. So Mandy Starr is the director of the Healthcare Research Center at the Office of Financial Management, and they are critical partners with us on a number of different projects that support healthcare information, our forecasting for the Medicaid population, the uninsured information. Mandy's group has really been a great partner with us on a number of different projects. So I think we're excited to hear about this new assignment from the legislature. Mandy?
Yeah, can everyone hear me?
Yes, thank you.
Okay, I'm going to keep my camera off only because I start having bandwidth issues when I have it on and present. So I'm just going to talk about some of the updates to the RCW 43.370. So this is the statewide health resources strategy. And I think you all are controlling my slides over there. Yeah.
Yes.
Okay. So I'm going to give a little bit of a background so we're all sort of on the same page here. So RCW 43.370, this was a law that was originally enacted back in 2007. It directed OFM to come up with a statewide health resources strategy. We now refer to that as a state health plan. OFM did release their first attempt at this back in 2010. That is available online. And if everybody gets these slides, there is a link in there to that report. The big issue with that report is that it identified some major data gaps that we had here in the state. And those data gaps were barriers in meeting some of the requirements of the RCW. If you read through the RCW, it's very detailed on the type of information that's needed, some of the strategies. So what we've done for the past 15 years at OFM has been trying to fill in a lot of those data gaps, and we've done some partial updates to the 2010 report. We released one in 2022 looking at hospital utilization. Let's go to the next slide. I can go to a little bit more detail on the data gaps that were identified. So we had 4 main data gaps that didn't exist back in 2010. So one was a census of active healthcare professionals. So detailed information about professionals. So not only where the location of their practice, what the practice actually looks like, type of insurance accepted, things that are beyond just basic licensing information. We lack at the state a census of healthcare facilities. So knowing where those facilities are located, the types of facilities, the capacity of these facilities, that's been a struggle getting that type of a census available. The all-payer claims database, OFM actually began work on this in 2014. It began taking in claims in 2017. So this is the Washington All-Payer Healthcare Claims Database. So at the time of the report, we didn't have one. We've made substantial progress since then. And then the other big piece that was missing is a comprehensive population-based socioeconomic and health database. So this is very similar to what California has, which is called the California Health Interview Survey. So it's not just understanding people's healthcare conditions, but it's also understanding how they access healthcare and barriers to accessing healthcare. Next slide. So I'll talk a little bit about how we've gone about filling in some of the gaps for these 4 main data gaps. So back in 2010, we had a staff member who developed a methodology to estimate several types of healthcare professionals by geographic area. And we've been releasing reports periodically ever since, and we tend to focus on MDs, PAs, and ARNPs. We look at FTE counts, we look at the demographics that are available. We use data from multiple data sources in order to come up with the estimates that we have in our reports. Back in 2011, there was actually a survey that was done of healthcare providers looking about hours and days of practice, number of locations and patient services. We haven't had the funding since then to be able to replicate this survey. And then we've also just done additional research just on workforce issues, and those are all available on OFM's website. Next slide. So when it comes to healthcare facilities, for a while we had a website, Washington State Monarch, which had information regarding hospitals. The one problem we run into is that AHRQ at the federal level stopped funding this particular project, so we had to take the website down. So unfortunately, we haven't been able to update the information since then. But we've been able to do other types of research. So we've looked at distance traveled for primary care. We looked at different variations and hospitalizations and for different types of hospitalizations. We pulled some information from Department of Health on the hospital financial reports. We've been able to look at hospital mergers and acquisitions. We've also looked at hospital capacity. And now with the all-payer claims database, we can actually glean some of this information around healthcare facilities from the all-payer claims database. And we will be utilizing this in the update. Next slide. And then there's a little bit more about the all-payer claims database. It was launched in 2017. The website, the Washington Healthcare Compare website, was launched in 2018. The problem is the all-payer claims database isn't 100% comprehensive. Very few of our databases are. It lacks the self-insured claims. We don't have federal claims in there, so we don't have any TRICARE. VA is not included in the all-payer claims database either. Even with these caveats, it's a pretty comprehensive database still. We are one of the biggest users of the data. We have used it in a variety of research projects. Right now, we're looking at the all-payer claims database data, and we're also comparing it to the CHARS database, or the Comprehensive Hospital Assessment Report. So it's the inpatient data, to try to see where the gaps are between those two databases. Next slide. And then on the Comprehensive Population Health Database, we've been utilizing a lot of the BRFIS data to try to fill in some of these gaps. So we've been trying to add questions onto BRFIS that get at issues around access to healthcare. Currently, for the 2025 data, we do have a medical debt question on there to try to understand how much people are having to pay out of pocket for healthcare costs. In 2012, we did a Washington Healthcare Consumer Survey, so that got directly at access to care utilization for both routine and emergency care. We haven't had funding to be able to replicate this type of a survey, but we do lack a statewide database really focused on utilization of healthcare resources, barriers to healthcare resources, and how people are accessing healthcare resources. Next slide. So with this past legislative session, Substitute Senate Bill 5568 did some updates to the current RCW, and we will have new state health plan will come out in 2027. So some of the updates, they updated some of the definitions of the types of facilities that we need to look at. They have enshrined in there data access for us to have data access at multiple agencies. They've also enshrined the confidentiality and non-disclosure of the data that we do receive from other state agencies, especially around healthcare. They've included principles of health equity, and we'll be describing that a little bit more in detail once we come up with how we want to approach health equity in this particular work. We're going to be holding 2 hearings. So we're going to have one hearing that'll be related to the approach. So that will be in 2026. And then we'll have one hearing for the final report, which we will be doing in 2027. And we're also going to be including projections and policy recommendations. These need to go through 2032. And then after 2032, we'll be updating it every 4 years. Next slide. So right now, what I can tell you is some of the principles that are going to be guiding the work as we update the state health plan. We are focused on being transparent. So we'll be transparent at both our methodology and how we define things. We want groups to be able to reproduce our results. We also want to avoid duplication. So we'll be reaching out to a lot of our partners here, both at the state level and also in academia and across the state, to avoid duplication. We don't want to be putting out analysis that other groups have already done. We have a very small staff to do all this work, and so we would like to be able to leverage as much as possible work that's already being done at the state. So we would really like to be able to get everyone access to other reports or just data analysis that other groups are already doing. We don't want to come out with different definitions or different estimates for things that other groups already have established a routine on reporting. And we want to involve partners at all levels. So we want to have all levels of government. We want to have our tribal partners in here, healthcare researchers, healthcare associations. We'll be putting together a technical advisory group that we will probably be meeting in early fall to talk with, and to have that group give us feedback and act as a sounding board for a lot of the work that we're doing on this state health plan update. Next slide. So current progress. So I had a retirement happen within my team, and I have 2 full FTEs that are going to be working on this. One of them just retired. We just hired that person It's a replacement. That person will be starting on August 1st. So we'll have to get them up to speed. Right now, we're setting up our tasks and our timelines. We are going to be building the technical advisory group that I had just mentioned. One of the first tasks that we're going to be doing is trying to build a state agency data inventory. So contacting a lot of the state agencies, we have lists of a lot of the data that other agencies have. We're going to be reaching out to find out if we're missing some data sets or databases that other agencies may have we're not aware of. This is to help identify any data gaps that might still exist within the capacity of the state. We're also going to be reviewing a lot of our data sharing agreements that we currently have. We will be submitting an IRB application for some of this work as well. And then I started right there, the building the technical advisory group, because I do have an ask for this group. And if people want to be involved in this, either through being on the technical advisory group or just wanting to sit down with us and have conversations about the work that your groups are currently doing, we are definitely open to partnering and talking with as many people as possible. And the next slide. Yeah, so does anyone have any questions? We're still in the early stages of it, but we are open if groups have, if you really want to get your work out there, if you have analysis that you've been doing and you really think it should go into the state health plan, we would love to reach out with everyone and to talk with them and to make this state health plan something that is useful and something that is already leveraging what we're already doing here at the state. Does anyone have any questions?
Thank you, Mandy. That was great. I would say, I know you've been participating in our data advisory committee for the board. Thank you for your commitment to that. And I believe our data group has started a inventory as well, so we can make sure that you have access to the inventory they've already started. And I believe
Perfect.
you're talking with our team who's interested in being part of your technical advisory group.
Yep. Yeah, we've got a list of some people who already we've already been engaging with. But if there's others that we may not be aware of, or if there's certain groups that maybe you're already working on something around healthcare access, definitely reach out to us. We definitely want to know what other groups are doing and be able to highlight the work that's also being done in the state too. I think this is also what we want to be able to show in the report too.
Yeah, and we think this board offers you an opportunity to have some transparency on your work as you want to bring updates to this group as well, or the data advisory committee. That will be useful.
Yes, I think I have some on my calendar in the future about bringing some updates here later on.
Perfect. I'm just doing another check from board members, see if there's any questions or comments, looking for hands. Not seeing any at this time, but we do know where to find you. And
yes, you do.
We definitely appreciate this update. So thank you
All right.
very much.
Well, thank you.
All right, Ross, I'm just going to do a check with you. I know we're a little bit ahead of schedule. Should we do the break now? And then I can ping Evan to be here early. Oh, he's already here early. Very good.
Yes.
So we should transition to break.
Yes.
Okay. So we'll go ahead because we do have a 3-hour meeting. Some of us do need to have a break. So we will take a 10-minute break now and be back just shortly. Are we ready to start back after the break? Looks like. Okay. Thank you very much, everybody, for allowing us a few minutes to get up and stretch. I see that Evan has joined us, so we will move into tab 8 and continue our overview of the federal impacts from House Resolution 1. And I will say our team has been madly working on not only this federal bill, but the new federal announcements that come to us about weekly at this point on different program changes, literally. So there's a lot of work underway. It impacts not just the Medicaid program, but the marketplace and some of the other commercial products. But this will be our focus today on our Medicaid program, our federally funded Medicaid program. And Evan can do an introduction. He's already shared some of this today at the Senate Healthcare Committee. So if people wanted to go hear another version of it, you can catch the Senate Healthcare Committee from TBW that was on this morning. Evan, would you like to jumpstart us into all of the fascinating impacts for Medicaid?
Yeah, thanks, Michelle, and thanks, Cost Board, for having me once again. For those who might be unfamiliar, I'm Evan Klein. I'm the Special Assistant for Legislative and Policy Affairs at the Healthcare Authority, and I handle both state and federal relations for the agency. And this interim, it has included quite a bit of heavy engagement on the federal side. I think Michelle points out, some healthy context here, and I know that you had some presentations earlier today from Jane and Ingrid related to some of the other federal budget impacts on the marketplace and our commercial insurance coverage here in Washington. I'm here to talk a little bit about the Medicaid impacts, and particularly the kind of healthcare authority side of those Medicaid impacts, acknowledging that there are some other impacts that touch on some of our sister agencies in the budget as well. Before diving in head first, and this is a lot of material and it's pretty weedy, and I will acknowledge what's in your packet is kind of the comprehensive PowerPoint that we've produced to give some background on the Medicaid program in addition to the federal budget. I'm not going to walk through all of that today, but I do think it's really healthy context to acknowledge none of this is happening in a vacuum. Prior to the change in federal administration, there were actually a number of federal rules that had come down in the Medicaid space that impact our program. They're relatively comprehensive. They impact the Medicaid managed care quality oversight. They impact prior authorization standards, eligibility and enrollment, and is work that the agency and the state really has been very heavily engaged in to work towards implementation. There's some juxtaposition in that a lot of those rules were focused on improving quality, improving state oversight, improving access for our clients. And then now we kind of have this kind of separate set of federal policies that are really directionally towards kind of degrading and eroding some of that access to coverage. So I'm going to step through that today. Happy to take questions throughout, but also want to acknowledge a lot of the material you're going to see obviously is in your packets, but lives online, and we can share those links for you. I'll drop them in the chat as I have the chance probably towards the end of the presentation. But both a PowerPoint and a fact sheet that you are welcome to share. They are public. And to the extent you're engaging with any stakeholder groups, constituencies of your own, or could use the materials for your own purposes outside of your role on the cost board, do encourage that. We've been trying to keep those links up to date and kind of iterating on them as we've had more information about the federal budget. I anticipate at this point they may be relatively static, but they're there and they're accessible by you and the public in case the material is helpful for your digestion of what is impacting Medicaid space. So with that, you can go to the next slide. High level here, the federal budget, we've really started engaging on this starting back in March, and it's been over a 4-month process at this point of reviewing and analyzing different policies that have been proposed at the federal level. But the budget itself, the HR 1, passed Congress on July 3rd, was signed by the president on July 4th. It contains a number of provisions that impact Apple Health and the individual market. I know you heard about those marketplace provisions in more detail. We do have a little bit of material that lives kind of within our deck, speaking to kind of the marketplace interaction, acknowledging that the people that we serve tend to be the same. There's a lot of churn between Medicaid and the marketplace. So I think it's important to acknowledge none of this is happening in isolation, and an individual who may be impacted by Apple Health or Medicaid provisions that impact the Medicaid space may then also have to encounter the changes in special enrollment periods or premium tax credit provisions on the individual market as they go seek coverage in other places. We are anticipating the impact to, this will impact hundreds of thousands of Washingtonians. A lot of the impacts I'll talk to are very acutely focused on the Medicaid expansion population. So those adults that we expanded Medicaid to at the outset of the Affordable Care Act. It's roughly 600,000, I think it's about 620,000 individuals enrolled in our programs to date. There are impacts that broadly impact, that touch others who are enrolled in Medicaid outside of that expansion population, but there are kind of some very targeted provisions. So, it's going to impact hundreds of thousands, and we anticipate hundreds of thousands may lose coverage as a result. And then the one piece, just to acknowledge, we're still working on assessing the impact of the budget to our state programs, what implementation will look like, how long it'll take, how much it'll cost, and some of the intricacies in it. And we are still awaiting federal guidance on many of the provisions as well. So we may not have all of the details to questions that we're going to encounter over the coming months, but working in earnest to try and unpack these provisions for the state, what they mean, and how we can move through that. And I think to Ingrid's point, mitigate the impacts on our clients. Next slide. Thanks. So just at a high level, these are a couple of the provisions. Really the focus here is on kind of the major Medicaid related provisions. There are some others that I won't touch on today, but that made it into the final version of the budget. We should acknowledge there are a number of pieces that had been contemplated by Congress and that fell out. Major FMAP or federal funding provisions tied to the state's coverage of non-citizens and immigrant coverage programs, other FMAP provisions. There was some contemplation of reducing the state's federal match rate for the Medicaid expansion population as an example, which would have had hundreds of millions of dollar impact per year on the state, in addition to some of these other policies. So there are some provisions that fell off. We don't expect that this is the only bite at the apple that Congress is going to take at the Medicaid program. And I think we've, heard that there's some new rules that are coming down the pipeline for things that didn't make it into the budget that they're going to try and attempt to do through rule. So we'll wait and see. But these are kind of the major provisions that did get finalized. Prohibition on federal funding to family planning providers, changes to eligibility redeterminations, work requirements, restrictions on provider taxes and state-directed payments, requirements around cost-sharing obligations for individuals in the expansion population, and some provisions around erroneous payments. And then, so from here, I'll get into a little bit more detail, but just kind of want to highlight where we are. So next slide. In terms of state funding and enrollment impacts, anyone who's been tracking this has probably seen multiple, publications that kind of speculate to the loss of coverage that may accrue from the provisions in the federal budget and the funding impacts associated with that. What we expect is that between work requirements, redetermination provisions, some of the pure changes in eligibility, there are some coverage restrictions for certain non-citizen populations, for example, that will lose coverage for 200 to 320,000 Washingtonians. That means, 200 to 300,000 people who are either uninsured or going to search for coverage on the individual market. You just heard kind of about the kind of affordability pieces and the erosion of subsidization of coverage on that marketplace. And then, in terms of, impact to the state, we do anticipate this is going to account for billions of dollars in lost federal funding. Some of that may come through because there's some specific restrictions on payment and funds flow, restrictions that I'll talk to on our state-directed payment programs, for example. And some of that will be accounted for as we lose Medicaid enrollment. The 50 to 90% of the dollars spent to cover an individual and pay for their services is coming from the federal funding. So, billions in losses. Most of this won't occur right away. I'll talk to kind of how these different provisions phase in over time. We'll see, I think we'll start to see some of the more acute impacts of these budget provisions out into 2027, 28 and beyond. But over the 10-year projected impact of the budget, certainly, billions in loss of funding into this is money flowing into our delivery system today. Next slide. So the first provision to speak to, this is the most immediate of all the provisions in the federal budget, and one we've been kind of grappling with here at the Healthcare Authority, but is a prohibition around payment for protected health services. The budget prohibits federally funded Medicaid payments to nonprofit organizations that primarily engage in family planning services and also provide abortion services. It's a very targeted provision towards Planned Parenthood, and it's a restriction on federal funding through the Medicaid program going to those providers. It only applies for 1 year. It was originally a longer term. There were some rulings by the federal parliamentarian here that created some restrictions, but it'll lead to a reduction of around $11 million we project in federal funding over the next year. The good news is Washington State has committed through partnership with our governor's office and some key state legislators in funding these services for critical providers within the state, with state resources. So backfilling that loss of federal funds so that we can maintain access for Apple Health clients who need family planning services in Washington. But just kind of the first instance of, having to start to supplement federal funding with state dollars and system changes to accommodate that as well that we've been working through. And that took effect immediately. So this is a provision that was effective as of July 4th. There have been some court proceedings. I won't get into detail on that, but that stayed that originally. But we anticipate that at some point there may be a need to swap in state funding. Next slide. The next provision, this takes effect December 31st of 2026. This is a change to the frequency of eligibility redeterminations in the Medicaid space. We currently redetermine clients' eligibility every 12 months, and this will require us to redetermine their eligibility every 6 months. The good news is we have systems set up to automate this to the extent we can. Over 80% of our clients should hopefully be able to get automated eligibility redeterminations, but it's those others who need high touch from our client services to manage their eligibility determination. Maybe they need more documentation. They need to. There's a change in their income. There's a change in their employment status, and they have to report that to the agency. This is obviously an additional touch point for folks who have busy lives, may not have a comprehensive understanding of the delivery system, or we know how complex it is to engage with eligibility systems, and we anticipate this is going to lead to losses of coverage, mostly for procedural reasons. That we're here to work through with our clients, and we hope we can mitigate some of those impacts. But we anticipate, this is an additional burden. And again, this is a provision that targets that expansion population. So the roughly 620,000 adults that are enrolled in Apple Health. Next slide. The next provision also takes effect December 31st of 2026. This is work requirements. You probably heard quite a bit about this in the news, but it's a requirement for adults aged 19 to 65 to either work or engage in what they kind of frame as community engagement for 80 hours per month in order to receive eligibility. It looks back about a month prior to enrollment to ensure that you met those requirements prior to enrolling in Medicaid coverage, and then requires documentation and reporting as part of your continued enrollment in a Medicaid program. This is another provision that was kind of targeting that adult expansion population, and one that we would anticipate is going to create significant burden both to clients in managing these new requirements, also to the state in managing system changes and implementation. Next slide. Most of our Apple Health clients work, and I think what we've seen from other states that have tested kind of work requirements is that it's often not the individuals who are working. It's not often individuals who are working or not who are gaining or losing coverage. It's procedural reasons, right? It's the reporting requirements. It's the additional complexity of engaging state systems and providing information to the state that creates the burden. Projections estimate that over 180,000 individuals in our Medicaid program could lose coverage as a result of these provisions. But the important note is this is an additional hurdle for over 600,000 individuals to just retain health insurance coverage. States, I guess the only good news here, states do have the ability to apply for a waiver to delay implementation. What we don't know is the likelihood of the state receiving that waiver. And if we were to receive a waiver, how long implementation could be delayed. There are requirements in the federal budget that states make what they're framing as a good faith effort to come into compliance as part of the waiver. We don't have any guidance or additional information about what that means yet. Hoping to get additional guidance late this calendar year. But know that regardless, there's some major systems changes and major implications for us to implement these policies. Our staff have already started working with sister agencies to manage compliance and think about what this would look like, including connecting systems with our employment security department so that we can try to mitigate the burden on individuals through as much automation as possible. We're also acknowledging that these provisions, these work requirement provisions, are very similar to provisions that were placed on SNAP. And so other programs that are administered by the Department of Social and Health Services. But again, some significant impacts to our clients. Next slide. There are a number of exemptions here, so I won't go through them all in detail, but just acknowledging, there was some look at, individuals who have medical conditions, who may be in other, circumstances that require that they maintain coverage and may not be able to work or meet the community engagement requirements. So there will be some exemptions, and we'll work through those to, again, ensure that any of our clients who may meet those exemptions are able to retain coverage as we kind of build out system changes here. Next slide. So one of the more acute provisions, I think, for awareness by this group, by Cost Board, are the impact on state-directed payments and provider taxes. So Washington State, along with a number of other states around the country, use both of these kind of tools to draw down federal funding to be able to increase payment in the Medicaid program. I know you all have talked about it quite a bit before, but Medicaid payments kind of traditionally lag behind payments from other types of coverage, Medicare, commercial insurance, especially. And I think have largely been seen, at least in certain, for certain services or facilities or benefits, as inadequate. And so something that the state has worked through over the past number of years is leveraging provider taxes to try and draw down new federal funds to the state, and then leveraging state-directed payments to increase reimbursement rates. The state has used state-directed payments for primary care and behavioral health reimbursement rates, also for increasing hospital payments. Our hospital safety net assessment is probably the single largest state-directed payment program that we administer. So the budget, it prohibits new provider taxes. It also ramps down existing provider taxes from 6% to 3.5%. Provider taxes may be a misnomer here, and thinking about this as kind of healthcare taxes, but it effectively places a cap on a lower cap on the amount of net revenue that can be taxed by the state to draw down federal funding. And then maybe the more, I think the larger impact for Washington in particular is this prohibition on new state-directed payments. So it prohibits new state-directed payments from exceeding Medicare payment levels and requires existing state-directed payments to reduce by 10% per year beginning in 2028 until they reach Medicare levels. It does not apply to all state-directed payments. So I think the silver lining is the state-directed payments that we leverage in our Medicaid program for increasing reimbursement rates, particularly for like primary care, behavioral health providers, non-emergency medical transport, are unimpacted by the federal budget. but it does apply to inpatient and outpatient hospital services, nursing facility services, and certain services that are provided at academic medical centers. Our two largest programs that we administer here at the Healthcare Authority, one is the Hospital Safety Net Assessment, and the other is a University of Washington centered kind of state-directed payment program, both of which are used to increase reimbursement rates for hospital services in the Medicaid space, and on average have increased reimbursement rates above Medicare levels. And I think we've talked about that with this group before, but paying hospitals closer to 120% of Medicare in the Medicaid program as a result of those increased state-directed payments, some of which took effect as recently as 2024. So there'll be some prohibitions and there'll be some rollback of those over the coming years. Next slide. For the Medicaid provisions, we anticipate that once fully reduced, the impact would be around $1.5 billion annually in reduced spending on hospital services in the Medicaid program. We don't yet know exactly when we would get to that kind of all-in provision. As I noted, this budget provision takes effect in 2028, but it kind of phases down over time, 10% per year. But just want to kind of acknowledge the gravity. And I think when you hear about some of the delivery system disruption that is anticipated as a result of the federal budget and the reduction in spending towards kind of safety net providers, this is one of the kind of singular provisions that will have a very acute impact as we get into the out years. Next slide. Cost sharing, another requirement that was included in the budget. We're still waiting on some specifics. I think we're going to need additional guidance from CMS to really better understand the true implications of this on our clients. But beginning in October of 2028, it will require that adults pay cost sharing of up to $35 for many services. There are a number of services that are excluded from the provisions, including primary care services, emergency services, but there will be a number of services for which there will be a new cost sharing obligation. As you're aware, the Medicaid program does not require individuals to pay out of pocket for services today, in large part. The application of this provision is on adults that earn over 100% of the federal poverty level. We anticipate, based on current enrollment figures, that could impact over 75,000 in enrollees in the program. It's certainly gonna drive out-of-pocket spending. These are individuals who are earning as little as $16,000 per year. So any dollar spent on healthcare is going to create a barrier, either them faced with really difficult decisions about what they don't spend money on as a result, or foregoing care, which is the exact thing that we have the Medicaid kind of safety net to prevent. Next slide. This is a bit more in the weeds and really starts to get out into the out years. So I'm not going to spend too much time here, but just acknowledging there is this very kind of, again, weedy provision in the budget that impacts kind of what's called erroneous payments in the Medicaid program. It's really around taking away the ability of the federal government to waive penalties on states when states are making good faith efforts to improve payment policy and manage accurate payment policy in the Medicaid program. The top line here is that on average, states around the country have erroneous payments that exceed the threshold that's set as kind of the benchmark for penalizing states in federal statute. And this takes away the ability of the federal CMS, federal government, to kind of waive those penalties on states in large part. So a lot more in terms of specifics that we'll have to unpack on this. We'll surely await some additional guidance from the feds, and it is a provision that won't take effect for about 5 years, but could have some kind of significant impacts if we face penalties. And you can jump to 2 slides further. And then just kind of wrapping up on some of the major provisions here, rural health funding. This is something we're just starting to talk about outside the agency. It was really new at the end of the budget negotiations. It was a $10 billion fund to states from 2026 to 2030. The funding can be used by states to support health transformation projects with a focus on promoting care. I believe that should say $50 billion. Right. But funding that it can be used by states to support rural health transformation projects, a focus on promoting care, supporting providers, investing in technology, assisting in rural communities. It's a bit of a grab bag. We're waiting on further guidance, including a notice of funding opportunity from the federal government. That we anticipate will come in mid-August. So we don't necessarily have details around expectations for state applications, but it's kind of a one-time process for states to apply for this funding. The funds, there's a methodology in the budget around how the funding will be distributed. It's largely seen as a bit of a stopgap to backfill some of the cuts, but not seen as actually getting to kind of sustainable funding for our rural providers, particularly in light of the major cuts that are coming in the budget elsewhere. So we're working with some of our sister agencies towards an application. There's going to be a lot of external engagement around this funding, we know, with kind of rural providers, with community groups, with legislators, with tribes. And so a lot more work to come, and in very short order, because the applications all have to be approved or denied by December 31st of 2025. We don't actually know when the application deadline will be yet, so working in earnest here. Next slide. And I will get you, I apologize. I don't know why I have a $50 billion number in my head, but we'll get you the right number on the rural health funding piece. But then just other provisions, as I noted, there's some other provisions I'm not going to spend a ton of time on, but that do have some acute impacts for different populations in the Medicaid program. Changes to Medicaid eligibility for refugee, asylee, and other non-citizen adults. That's effective in October of 2026. Shortening the period of retroactive coverage eligibility from 3 months to 1 month for adults beginning in 2027. Address verification processes. And then some of the significant limitations on our other sister programs, kind of the individual market programs, SNAP, TANF, other social services as well. So a lot going on, a lot we're still unpacking, a lot of details we don't have today, but wanted to give you that highlight. So with that, I'm happy to pause. I can stay on for questions or turn it back over to the cost board team.
Thank you, Evan. I'm just monitoring to see if there are questions from the board. I know there were some comments in here in the room, but I don't think they want to be on the record necessarily.
I mean, Evan, so the changes in Medicaid eligibility for refugee, asylee, and other non-citizen adults, right? Those are across Medicaid, Medicare, and the marketplaces. And it just seems like rather than being other provisions, it should sort of have its own slot and to reference the Medicare changes as well. I think the Medicare changes are later, right? I think they're 28. But still, it's a big change.
Yeah, I think that's right. I think speaking to it here, because there's not much in the way of additional details we have today, and kind of how we're going to manage eligibility provisions. I think we're also still unpacking how big of a population this is. What I can say to your point, Jane, is we anticipate this could impact north of 30,000 individuals, depending on the specific eligibility categories that get kind of swept up by the provision that would lose coverage. And those are individuals where we have, program. The good news is Washington has been has set up other programs to try and assist individuals who didn't have anywhere else to go, particularly for citizenship status. But many of those programs are limited in terms of funding and scope, and our ability to kind of really backfill coverage for these individuals right now is pretty limited. And so it's a great point. Don't want to diminish the very real impacts associated with this provision in particular.
And I'm trying to recall whether, is this provision also impacting SNAP? I can't remember.
I believe so. Yeah.
Yeah.
And I think some of the SNAP provisions, I'm not as familiar with the implementation dates associated with those provisions, but I believe some of them take effect sooner than the Medicaid provisions. I don't know if that's the case for
Right, I think some
their
of the
eligibility changes.
food requirements were effective near immediately.
Yeah.
I see Kim has her hand up.
Yes, thank you. I just want to confirm, I might have missed it. I see the bullet reads changes Medicaid for refugee, asylee, etc. Doesn't, so I want to ask explicitly, does it eliminate Medicaid coverage? What does it,
Yeah,
what does changes Medicaid mean?
yeah, and that might be a typo here in the slide. It changes the eligibility criteria. It eliminates funding for these individuals. So we can no longer receive federal funding for individuals covered by these programs. So I think still unpacking what that will mean for the actual population, here in Washington. But yeah, it'll eliminate federal funding for these individuals. Yeah.
Thank you.
Eileen.
So I'm sure that you guys are working on this, but can I ask that the board get like a table for each, what's happening each year and how many people or how much money it impact? I mean, I'm not asking for immediate, but I know I'm sure you're putting it together anyway. So I just would like to go on record that I'd like to see that when it's good.
Sure. We are, of course, working with our summary tables on timelines. That is, we have actually a one pager that's available. I think Evan will put it in the link for us, but of course the team's working on their budget assessment. We have some immediate budget packages that we'll need to submit in our decision package requests to the governor's office in September. So the teams are working really quickly to assess the immediate impacts and thinking through the system impacts as well, and what, how we begin some of that system work that is already in a full queue, if you will.
Well, and I'm sure trying to figure out how much it's like extra staff that you're going to need. That's another expenditure.
Yeah.
Goes in here.
Absolutely.
Yeah, and I did just put in the chat the links to the materials that we have publicly that I mentioned at the outset. One of those is a fact sheet that includes a table with the effective dates for the provisions that we stepped through kind of in chronological order. And again, to your point, Eileen, I would emphasize this isn't happening in a vacuum either. There are state changes from the state legislative session that are driving system changes and staffing impacts. There are also federal rules that we're in the process of implementing, as I mentioned, that require system changes and staffing impacts. And we have a kind of a singular eligibility system in the state, ACEs, that manages eligibility for a variety of social services programs, and it's very old. And getting all of these kind of work orders in the queue in and of itself is going to be a large undertaking. Staging them and thinking through implementation is going to be really difficult. And something we've messaged, I feel comfortable saying it here because we've talked about it pretty publicly, is that with work requirements, for example, we don't anticipate an ability to come into compliance with those provisions by December 31st of 2026. We don't think that we would be able to update our systems aside from any of the other things that may need to happen, like staffing up to support individuals navigate the system. We don't believe that can occur in that time frame. So really working towards how fast can we go? What will it take? Do we need to apply for some of the waivers that exist in the budget provisions, et cetera? But a lot going on and a lot to unpack. Yeah.
And the other piece we didn't bring today are some of the other federal regulations or Medicaid director letters, other announcements that we get on a pretty much a weekly basis at this point that also will unravel some of our programs and or direct us to make some changes. So we are absorbing those, working through them rapidly, participating in Attorney General preparation for lawsuits on a number of them. So it's a very, very busy time, and the teams are working hard to keep afloat with some of these rapid changes and thinking not only about our residents, all the people we are covering in every single coverage program in the state, but our delivery systems and the health of our delivery system and the ability to deliver this coverage on an ongoing basis. Many opportunities to think through. But thank you so much, Evan, for that nice overview. And I think I will just ask the team to put the one pager available to the minutes of the meeting as well, because it'll be hard for people to get the link, I think, after the meeting. That would be great. All right, I think at this point, we were going to transition into a panel discussion from more of our board members who wanted to have opportunity to react to some of the federal information that we've just presented or that your own organizations are absorbing and thinking about. I think we have a tab with some questions there. Yes, tab 9. Thank you, Audrey. So I think we are teeing that up with Ken Gardner from the Health Benefits Trust, Kim Wallace, and a colleague from Labor and Industries, Dave, and I'm not going to get Dave's name right. So Kim, I'll
Yeah,
ask.
Dr. Dave Bonato, yes.
Thank you, Dr. Dave Bonato. And Bianca Frogner is going to help facilitate some of our conversation. So I think we were going to have Ken kick off. Is that right, Ross?
It will be Dave.
David, okay.
Yes.
All right. Sorry about that, David. Is he online with us?
Let me confirm. Dave said that he would join us at 4 o'clock. He was anticipating that Ken would go first.
Okay. Could we skip to Ken? Potentially.
Yes. Audrey, could you skip ahead? There should be. Oh, well, Ken, did you have any slides? I apologize.
I did not have any slides. It's a big bill, and if you'll forgive me, I've got a lot to say, but not a single slide.
No problem. Thank you. Sorry, Ken. Please go ahead.
So folks, I spent many years at the Centers for Medicare and Medicaid Services, so I'm pretty familiar with a lot of these issues. And I currently work with the SEIU 775 Benefits Group. Our organization, just for context, provides health and retirement benefits as well as training for about 60,000 caregivers in the state of Washington. These caregivers provide home health care for Medicaid patients in our state, allowing patients to stay in their own homes instead of needing institutional care. Home care typically provides a better quality of life for these patients at a lower cost than institutional or nursing home care. The state of Washington's model for home care is frequently cited as one of the best in the country, and we are very proud of the work that our dedicated caregivers do. Changes at the federal level are wreaking havoc throughout the healthcare system, from cuts to basic research to shifting public health policies and priorities. Significant cuts to foundational programs like Medicaid in the reconciliation bill are cause for concern for our organization, and no doubt for state governments as well, as we've just heard so well from Evan. At this point, we have signed legislation at the federal level, and my organization is really watching to see how Washington and the Healthcare Authority respond. We recognize that it takes time to analyze and respond at the state level, and our organization will adapt to the landscape when we better understand just how that will take effect. We recognize, for example, that the changes in policy on provider taxes may have a significant impact on our state's Medicaid budget. Some changes in the reconciliation bill take effect quite soon, and others over the next few years. We expect this to be potentially a lengthy adaptation. Now, I'd like to give you some of the top concerns from our organization's point of view. And then I'm going to talk a little bit about my personal observations as a member of this board and someone long involved in health policy, if you'll forgive the length. So first, here are 10 concerns from the point of view of our organization and the caregivers that we serve. First is that Medicaid cuts directly threaten caregivers' livelihoods. Home caregivers depend on Medicaid-funded programs for stable employment, And when funding is reduced, caregivers face job loss, reduced hours, and financial insecurity. Second, loss of working hours puts caregivers' health and retirement benefits at risk. Caregivers earn access to our organization's healthcare and retirement benefits through the number of hours that they work. Reduced hours due to cuts to patient funding could push work hours below eligibility thresholds, stripping them of essential protections. Number three is that fewer paid caregiver jobs mean fewer workers to meet demands. As funding shrinks and jobs disappear, caregivers leave the field. This worsens workplace shortages and puts pressure on remaining staff, leading to burnout and lower quality of care. Ultimately, this leads to a detrimental spiral of negative impacts on the broader system. Number four is that when caregivers are underpaid or pushed out of the workforce, clients suffer too. Services are delayed or reduced, leading to poor health outcomes and more hospitalizations at a greater cost for the system. Number five is that rural and urban hospitals will feel the strain when home health care breaks down. Cuts to home care can force patients into emergency rooms or long-term care facilities, overwhelming both institutions and creating a ripple effect down the line. Number six is that immigrant caregivers and their clients are disproportionately affected. Many frontline caregivers are immigrants themselves, and Medicaid cuts and new immigration initiatives jeopardize both their ability to work and their families' access to care, exacerbating inequalities in already marginalized communities. Number seven on our list is about people with disabilities. There is a significant potential for Medicaid cuts to impact client care and access to care for people with disabilities. The need for caregivers continues to increase, and this will only widen the gap. Number eight is that reduced public health investments in vaccine care and new policies on vaccine access negatively impact everyone. Caregivers often serve populations most at risk of vaccine-preventable illnesses. With less Medicaid funding for outreach and care, society is more vulnerable to outbreaks. Number nine is about cuts to reproductive health care services that hurt both caregivers and their clients. Caregivers are predominantly women, and many often rely on Medicaid for reproductive health care. At the same time, they care for clients who rely on the same funding for prenatal and maternal care. When funding is limited, many negative impacts can domino into more severe consequences. And number 10 is that the healthcare system enters a downward spiral without caregiver stability. When caregivers can't stay in their roles, clients suffer, hospitals become overloaded, and communities lose essential support. Stabilizing caregiver situations stabilize the entire healthcare ecosystem. When caregivers can't be provided a stable livelihood, the workforce is diminished and caregiving is not seen as a stable career. This then causes a downward spiral and lack of caregivers, potentially for generations. Now, speaking as a member of this board and looking at broader indications for our healthcare system, here are some of my personal concerns. First is access to coverage. As Evan has said very well, administrative hurdles will cause beneficiaries to be dropped from Medicaid coverage. Specifically, the new provisions about work requirements and more frequent eligibility redeterminations may lead to Medicare beneficiaries losing their coverage even when they would otherwise qualify, simply due to administrative hurdles. This impacts the beneficiary's access to health care and impacts our caregivers' livelihoods as well. The greater frequency of Medicaid redeterminations, while easily sold as a prudent measure to the public, can present a huge hurdle to someone who has difficulty understanding the system. People with limited English proficiency often don't understand the notices and forms. People with cognitive difficulties may also need assistance with redeterminations. People without stable housing will be hard to reach. In these and other cases, qualified beneficiaries may lose access to care simply because they don't receive or don't understand the paperwork for this enhanced qualification process. And as Ingrid said earlier, the reduction in ACA subsidies and other marketplace rule changes will result in a rise in the uninsured rate as well, which will have impacts throughout the healthcare landscape. I'm also very concerned about financial pressures on rural healthcare. The simple fact is that most of Washington state is rural, and our rural health infrastructure is already severely strained. Medicaid cuts will devastate rural hospitals and hospitals that serve lower income communities in more urban areas as well. The same may be true for federally qualified health clinics that typically serve low income communities and depend on Medicaid reimbursement for a large portion of their budget. These and other clinics receive their core funding from HRSA, the Health Resources and Services Administration, which has already seen large cuts in staffing and funding cut by 10 to 15%. The administration's 2026 budget proposes an additional 20 to 30% cut. For context, there are 27 HRSA grantees in Washington state with 379 service sites. These sites served approximately 1.1 million clients in 2021. I mentioned previously vaccine hesitancy and the cost of declining vaccination rates. I've heard a lot of chatter in infectious disease circles about the cost of declining vaccination rates, especially for childhood immunizations. To give a local example, consider the measles outbreak in Washington state in 2018 and 2019. There were 71 cases. And according to the Bloomberg School of Public Health, the total cost of that outbreak was in excess of $3 million, or about $47,500 per case when you include public health efforts and productivity losses. Measles was officially declared eliminated in the US in 2000, but now cases are increasing. Last year, there were 285 measles cases across the US. So far this year, there have been 1,288. The MMR vaccination is 97% effective with two doses. The state should do everything possible to encourage childhood vaccinations to reduce infections such as measles and also to save healthcare costs overall. Turning to the impact on immigrant communities, the legislation excludes refugees, victims of human trafficking, and many other legally present immigrants from Medicaid, ACA tax credits, and Medicare. This extends to green card holders for the first 5 years of their time in the US. As someone who has personally volunteered to help Afghan refugees for the past few years, I can tell you that culture, language, and fear are major components of the equation. When refugees reach our shores, they don't understand how our healthcare system works. They don't understand the costs. They don't understand communications from the state Medicaid agency, and they may or may not ask for help. It has been a struggle to get the refugees that I've worked with through Medicaid redeterminations. And while most of them have now successfully obtained their green cards, the institution of a 5-year ban on benefits hampers them during the time when they most need help getting a foothold in our community. Widely publicized ICE arrests and detentions, including at or near healthcare facilities, will drive reluctance in immigrant communities to seek care. Recent press mentions of ICE having access to Medicaid enrollment records may further increase immigrant reluctance to engage in the healthcare system. So the bottom line for all of this is that lost or degraded access to care creates hardship for both caregivers and patients. Each lost access point to care increases the stress on the remaining parts of the healthcare system. Fear and distrust will further erode the public health in our state. We must be thoughtful in how we address the many facets of this reconciliation bill. That concludes my remarks. Thank you.
Great. Thank you, Ken. I believe Kim is teed up and.
Yes, and Dave is here with us, I see.
Wonderful.
Thank you so much. Thank you, Ken. for your very thoughtful and very, very important remarks. So I would like to introduce to the cost board and to everyone joining us today, Dr. Dave Bonato, who is the research director of the SHARP program. SHARP stands for Safety and Health Assessment and Research for Prevention program at Washington State Department of Labor and Industries. Dave is a colleague there, and he graciously agreed to share some information that I think is very relevant. It's a little bit different than most of the information that we've been considering so far today. Department of Labor and Industries, of course, is the safety and health organization or agency in Washington State, and the Workers' Compensation Insurance Agency in Washington State, responsible for a lot of support, research, programming that assists employers in Washington, and of course benefits workers related to research, surveillance, a lot of data analysis, really understanding what is happening for the worker population in Washington with regard to hazards in the workplace, and other safety and health issues and challenges. So Dave, as our research director for the SHARP program, has a wealth of knowledge about all things safety and health, or maybe not all things, but many, many things, safety and health. But he is prepared to share today some very specific impacts of federal policy and budget changes that we're experiencing, have already happened or are anticipating. And so, Dave, thank you very much for being willing to come and address the group. Please take it away. Is Dave a panelist? Is he able to speak?
Dave should have received a panelist link.
Okay. So let's see. Are you able to make him a panelist? BONE235?
Yes, we will get him switched over right now. Apologies, Kim.
Oh, no, thank you very much.
All right, Dave, you have been teed up and introduced. I'm sorry you couldn't hear any of that. We had a delay in getting you transported in, but we are ready to hear your insight.
Oh, Dave, you didn't hear all the wonderful things I just said about you?
No, I did, Kim, actually. I wasn't.
Okay.
Yeah, I was like frantically trying to figure out how exactly I joined. Appreciate capacity to get me in. So thank you, Kim, for that introduction. Yeah, just a little more. I am a physician, internal medicine doc, occupational medicine physician. I've been with the Department of Labor and Industries for about 25 years. Our little research group, SHARP, is focused on preventing workplace injuries and illnesses. We do that through research and outreach to high-risk populations. And certainly we want our research to inform public policy. In L&I, there's major divisions: workers' comp, the Division of Occupational Safety and Health, and Labor Standards Division. We were set up to be outside of that framework, mostly because there's objectivity in what our work is hopefully not biased by the other divisions within labor and industries. Next slide. So I'm going to talk a little bit about the National Institute for Occupational Safety and Health, very different than Medicaid and what you've been hearing about. So I need to give you a little background. So in 1970, during the Nixon administration, there was lots of advocacy from labor unions and others to form an occupational safety and health administration, basically an entity to protect workers from harms in the workplace. And so what was passed was the OSH Act, the Occupational Safety and Health Act. Did two big things. First, it created OSHA, the Occupational Safety and Health Administration. You're probably all familiar with that. That is based in the Department of Labor. They create regulations to control workplace hazards and they enforce them. They also empower states to create their own programs that have to be at least as effective as the federal government. Washington State is one of 21 states that has a state-based or a state OSHA program, and they regulate private and public sector employers. There's some states that just regulate public sector employers. In the OSH Act, they also created NIOSH, the National Institute for Occupational Safety and Health. That's based in the Department of Health and Human Services in CDC. And two big mandates. First of all, is to do research on occupational safety and health problems and basically work on prevention opportunities to fix those problems. The second portion is to create education programs, in part to provide an adequate supply of folks to enable the OSH Act, but also to take care of workers and help businesses. So the story that really the transformation that's happening in the federal government in late March, early April, and then actually progressing through May, there was this reorganization of Department of Health and Human Services in which NIOSH was taken out of CDC to be placed in a new entity called the Administration for a Healthy America. In so doing, basically, they more or less fired everybody in NIOSH. So there's no entity called NIOSH anymore. Well, there is, because there's been litigation, a lot of political advocacy. But in essence, the plan at the federal level is to eliminate NIOSH in favor of this other entity. Just for perspective, NIOSH's budget's about $360 million a year, and there's estimates of the cost of occupational injury and fatalities at being $175 billion. That's both indirect and direct costs related to work-related injuries. Next slide. So NIOSH does a lot of things, and I'm not going to go over this. They cover most industries, certainly high-risk industries. They do a lot of outreach and training for workers. I'm going to focus on just a very small element of this, which is in the upper left corner. In order to basically train occupational safety and health professionals, they set up about 18 education and research centers throughout the country. We have one in Washington. It's called the Northwest Center of Occupational Health and Safety. And what these folks do is train occupational medicine doctors, occupational health nurses, ergonomists, epidemiologists, industrial hygienists, basically, again, to support the OSH Act, but again, to provide an occupational safety and health workforce. So in this reorganization, these are grant-funded entities. And, there's a cycle of renewal to basically compete for these grants. Ours in Washington has been around since 1977. And is well established as a very well respected research center. So in basically defunding NIOSH, they defunded this entire mechanism of training occupational health physicians. I'm sure most of you know that most other medical specialties, such as internal medicine, surgeons, all of those training programs are funded through Medicare. So NIOSH and the funding of occupational safety and health professionals is very different. So what's the impact? Well, next slide. First of all, there's really already a shortage of occupational medicine physicians and occupational health providers. And there's some research to basically support that, when you're managing a workers' compensation claim, then when you have someone trained in occupational medicine, there's cost savings. Now, what do occupational medicine docs do? So I'm trained in more or less assessing whether or not somebody's injury or illness is associated with work, basically establishing causation. And in so doing, bill the appropriate insurer, right? So, I see somebody with, say, asthma, they're working in a cedar mill. Well, there's a well-established link between cedar dust exposure and work-related asthma. I can file a claim and go through the administrative process. And then, that worker basically is ill, and there's sort of decisions. First of all, obviously decisions related to how to treat that person most effectively, but then there's decisions about, when is that person safe and able to return to work, and sort of efforts by occupational medicine docs to prevent long-term disability. And so in essence, I actually recognize that somehow the citation, which I will send to you all, the asterisk was for a citation of a peer-reviewed publication in the Journal of Occupational Environmental Medicine, citing some of this data from California about the savings that's provided through occupational environmental medicine docs. So that's all I have to talk about. There are lots of other things that could be shared. I do want to say that SHARP, my little research program, has done a lot of work about cost shifting. So we know that workers get injured or made ill at work, and they often do not access workers' compensation. So they are being cared for by other entities, whether or not it's Medicaid or private health insurance or non-insurance. And we're literally going to publish about 50% of work-related injury and illnesses do not end up being paid for by workers' compensation. So that's an issue. I'm sure that may or may not, I don't know how exactly this will be impacted, say, by Medicaid cuts or other insurance issues, but certainly that's in the back of my mind as a pretty significant issue. So that's all I have to say. So thank you for inviting me. I'm happy to go on and on about other portions of NIOSH, but I think this is the most relevant to this group.
So Ross and Michelle, may I just make a comment that as a member of the board who has spent most of my work life in healthcare in various capacities, but never in the world of workers' compensation and industrial insurance until 6 years ago. I guess I just wanted to add a comment that my time at the Department of Labor and Industries in heading up the Office of Medical Director in workers' compensation has been just really illuminating. And I've learned so much. I just want to share that for all the years that I worked around and in the health system and healthcare system, I was not aware. I did not have a grounding or understanding about the healthcare, the medical services, the challenges and struggles of recovery and return to work that people experienced just because they're employed, and they have. I think it is part of what's really interesting and a little bit of a campaign, on my part right now, is to invite to share, the information about the very, very important part of workers' compensation that's basically, getting the right care, proper necessary treatment, medically necessary treatment, timely, to injured and ill workers under workers' compensation, industrial insurance. And so I just appreciate Dave so much for you coming and just sharing this little bit about the cuts and the impacts that we're experiencing because of changes in federal policy and funding. But I think it's really an opportunity to highlight a very big picture, a shared the landscape that we are all a part of, and just to make a special point that there's an awful lot of healthcare that happens under workers' compensation in all states, and that it's easy to sort of separate out and to kind of forget about that healthcare when so much attention is paid, understandably, to health benefits and the coverage from other payers, but of course the healthcare systems in Washington State, the providers, are seeing injured ill workers. They're treating injuries and illnesses that people experience because of their directly tied to their work. And of course, many illnesses and injuries that happen that have nothing to do with work. So thank you very much. I guess I think it's important for us to pause and consider, the fact that many people experience significant harm and have long paths of recovery because of an injury that happened one day when they went to work. And so, it's a very powerful thing, when you consider. And so I personally have been reminded and kind of stopped in my tracks with stories about people who do suffer, not, mostly relatively minor or, injuries they can recover from. But there are, of course, very, very severe and significant injuries and fatalities that occur because someone, showed up for work one day. Thank you. I thought I would just make that point that we're all in this together, and it's an awfully big. There are many, many, many people impacted, and it may be that workers' compensation was not top of mind for some of us. So we're very pleased to have the opportunity to share about it today.
Thank you, Kim. I think that was well said. And I appreciate you bringing Dave to share the insights, and Ken also sharing broader insights. All of you were helping point out that we have many layers of impacts that we haven't yet addressed. We talked about just a few, and it's helpful to keep seeing the bigger picture. There are many ripples here. I'm sure there are additional board members that have perspectives to share, and I see there's a question in the room as well. Eileen?
I just had a question for how many Washington workers are handled by occupational environmental medicine physicians at L&I, and how many of those docs are we going to possibly lose because of cuts? I guess that I'm just curious. I worked in a physiatry clinic, so I know we took care of a lot, but I also know that we got to pass off some.
Yeah, that's a great question. So I'm focusing in on sort of the training programs, and those training programs produce anywhere from 2 to 4 residents a year. Nationally, it's somewhere between 50 and 100 per year. That's actually significantly down from the past, say a decade or two ago, where there were, basically more than 100 or 200 per year coming out of training programs. In Washington State, there's provider choice. So workers can go see any healthcare provider. They need to be in the provider network. So I don't have the exact estimate of the proportion that are being treated by occupational environmental medicine docs. OcMed docs actually tend to sometimes receive a lot of referrals on sort of complex cases. And so that's an area where they may touch and improve the quality and outcomes of the treatment for an injured worker. Kim, do you have any sort of comment on that? I actually should look at that. I can find out the number of board certified med docs actually in the proportion of workers cared for by them. So,
Yeah, the only additional comment I would make is that there are differences in terms of the preparedness and the willingness and the ability for occupational medicine trained providers to support and assist workers in getting released to work, back to work sooner rather than later. There are differences in the training and the orientation for occupational medicine trained providers versus versus other disciplines. And that's not a pejorative statement at all about the many, many, many other types of healthcare providers who see injured workers in Washington. But one of the really significant challenges in workers' compensation is that many physicians and APRNs and PAs and other practitioners tell us that they really feel ill-prepared. They don't understand how to encourage and promote return to work, how to engage with the employer about modified duty, light duty, et cetera. So it's what we're very concerned about, the kind of extended time out from work, extended time that someone is receiving time loss payments, workers' compensation, or is just not really having the recovery trajectory that they could have, that they deserve. So I think that's what comes to mind, Eileen, when I think about occupational health trained experts assisting and supporting the recovery for injured and ill workers versus a physician or other provider that is doing their best and doing perhaps, looking for the most appropriate treatment, but doesn't have that lens or the really understand how to engage with the person, the worker, and the employer in getting that person back to work as soon as possible, supporting that transition back to work. And it's significant for the worker and their chances of recovery. And it's also costly.
I see there's a question in the room, and then I suspect that Jody may have a comment as well. So, Jane.
So I'm thinking about whether there are intersections between hearing that about half of people who are injured at work end up having their injuries addressed not through the workers' comp system. And I'm just thinking about the Medicaid work requirements. And like I know everybody's waiting for guidance from CMS about the exemption groups, but if you have somebody who's not working because they've been injured, right, whether they're on time loss or not, are we really creating a risky situation because, maybe they can't meet the work requirements, but they wouldn't be considered, quote unquote, medically fragile, and are we ending up leaving injured workers really sort of in a very bad spot? So just trying to connect the dots here. I know.
Happy thoughts. All right. I see Lois has her hand up.
I'm curious, every doctor's appointment I go to, when I sign in, it asks very specifically, is this related to an injury at work? So do we have any sense of why people would not just click yes and get into the workers' comp process?
Yeah, that's wonderful. A wonderful question. Yes, there is research on that. So I think people immediately go to this idea about friction between the worker and employer in terms of being an adversarial process and sort of potentially poor employment outcomes related to filing a workers' comp claim. But I think more broadly, there's sort of an administrative burden that goes along with workers' compensation that physicians sometimes don't want to deal with, as well as workers may not want to deal with it either. So I think there's barriers to entry into the system. And then I think there's, sort of a burden placed upon folks. And there's research to support that. There's another element of this, which is just familiarity of the workers' comp system. I had, 7 years of post-medical school graduate education, and I never filed my first workers' compensation claim until I started my occupational medicine residency. As a hospital physician in Bremerton, Washington, where tons of workers had at least asbestos exposure, whether or not it was just pleural plaques, but then asbestosis or measles. I never filed a workers' compensation claim. So the familiarity with the system, sort of ingraining sort of the training portion into just regular medical education would be wonderful. Nursing education and other sort of medical specialties, I think, would be well worth it. It's tricky. It's sometimes infrequent. Some clinics are seeing a significant portion of the injured workers and others rarely. So in those places where they're rarely seeing them, sort of having some ease of navigating into the workers' comp system and actually taking care of the worker probably would be beneficial. And Kim does this all the time. I shouldn't be speaking. This is your domain. I apologize, Kim. Okay.
Again, thank you. I don't want to put Jody on the spot, but I am just going to check in with some of our board members that may have different perspectives as well on some of the federal impacts that your organizations are seeing. And so, Jody, I'm sure you're seeing some.
Yeah, I'm with a federally qualified health center up here in Whatcom County. We serve 1 in 10 residents of our county, and we're already starting to see people fearful of being stopped because they appear to not belong here or because they don't, right? So we haven't really seen a drop in demand because we have plenty of demand, so other patients fill those slots. But I think the first thing we're bracing for is the end of the subsidies and the increase in premiums. That, what's the estimate? It might be a 75% increase in cost for the average recipient of insurance on the exchange. You know, we're grateful that most of the other changes don't start before October of next year. We're also grateful that it's up to the states about how the work requirement part will work. And I hope we track closer to Arkansas if we had to choose between the two instead of Georgia on what that part's going to look like. You know, I just think that as hard as it is already for people who are underserved and well-deserving, it's going to get harsher, and it's going to get harsher for everyone. And I think that we often have different points of view around this table and around other tables. And I think this is a time for us to really lean into what we share in common instead of what we disagree on. And, you know, hospitals are going to be hit really hard. Community health centers are going to be really hit hard. Schools, communities, labor forces, right? And so we're finding ourselves asking, how do we build coalition? How do we look for shared interests and shared strength instead of how do we try to grab our share before somebody else takes it? And so I just think that these are some of the things we're really going to need to think about collectively. 2/3 of our patients are Medicaid. And, you know, I think that the most likely path for that is going to be they go from Medicaid to self-funded, which means unfunded, right? And so this will have a huge impact for us individually. And then with all of the new creative interpretation of who is qualified for receiving federal benefit, some CHCs in the state have more than 70% of their patients who would have difficulty receiving services based on that new interpretation that came out 2 weeks ago. We have a smaller percentage of that for our own organization. But again, I think we need to think collectively, not about me, Unity Care, or about me as a community health center, but me as a part of the fabric of trying to serve the needs and support the well-being of residents of our state. And so it's such a sobering moment. And yet I think that there's opportunity here. Unity Care's origin story is when the Reagan administration it ended a lot of social programs and replaced them with block grants. And people in our community 43 years ago decided there are a lot of underserved, so let's do something about that. And so I'm trying to lean into the optimism of what will be the next origin story for all of us collectively to say, how do we do this now? Because we got kind of used to how things were. We weren't all happy about it. It's going to be tougher, but it's going to create new opportunities that will require and that will benefit from intervention and kind of reframing. And so that's kind of where both me personally and my colleagues and similar organizations across the state are currently trying to deal with the reality and anticipate the future that's headed our way really quickly.
Thank you for sharing that, Jody. And for those who might not be in the thick of that conversation that Jody mentioned with the new essentially public benefit charge, the state did file a lawsuit yesterday with 20 other states around some of that language. So we are participating in that because it impacts our federally qualified health centers, potentially some of them, all of our block grants, so our populations that receive SUD services and others. So that was filed yesterday. So many activities, again, underway to try and tackle each of these evolving conversations and the impacts that ripple across our state. I'm just looking for other board members that may want to add some perspective. I see
Yeah.
Bianca. Bianca has her hand up. Thank you, Bianca.
Thank you. Yeah. Well, thank you for the presentations. I have to say, Dave, I've seen a PhD student lose her NIOSH grant, unfortunately, here at University of Washington. So it has an effect not just on MDs, but also PhDs who are researching and understanding these issues. So I certainly am seeing that pain. And I'm curious too, if there's how you're reflecting on the added potential challenge of the caps on loans for medical professionals. I believe that there will be a cap of $200,000 for, I think, medical students to take out loans. And then I had a question for Ken, but I don't know if you've come across that, if that's come up at all as another deterrent for recruiting.
You know, Bianca, I'm deep in occupational safety and health. It's sort of far away from that policy issue. But I can definitely see it. I mean, I borrowed my way through all of medical school and exceeded that level, 30 years ago. So I can't, well, combined with college loans. So I just can't imagine like how people would finance that. I wish I had more to share.
Yeah, I mean, that's certainly an area that as a health workforce researcher, at like having that hat on, I am quite concerned about the various different kinds of loans that will either disappear or be modified and what that means for our future supply of healthcare professionals. It's a real concern. For Ken, I'm curious. I think the two things I kind of understand in this landscape of long-term care is that one of the things that also came out with the big beautiful bill is the prevention of or the not allowing the ratios to move forward in the long-term care in nursing facilities. Sorry, and maybe there's a little bit of an increase in investments in home and community-based services, but it's probably very, very modest. But it's certainly a continued shift away from nursing homes. I'm just curious your thoughts on those elements. I realize this is a 1,000-page bill, so there's a lot of information, but those are two things that I saw.
Yeah, I have to admit, I remember reading that they had put off implementation of the CMS rule that would increase staffing ratios at long-term care facilities, which is something that the industry had significantly lobbied the government to do, saying it was just too expensive. How could you have more than one RN in a nursing home? But I have not read the specific provisions there, so I really can't comment.
Maybe in general, the move towards home and community-based services, I know has been kind of ongoing across the country, but it seems like we may not have enough people to really even provide all the services people want.
It's true. I mean, here in Washington, the Benefits Group, if I can, tout my own organization, it's founded 20 years ago, as you can see by our background slide. We're celebrating our anniversary. And it started by standardizing a training program to recruit and train people to become home health care aides. And that is still the largest part of our organization. Over time, our goal is, our aspirational goal over the next 10 years is to make caregiving a career of choice, because it never has been before. It's been one that has been demeaned, that people said, well, we just shouldn't, isn't something that we can really support. It's just a bunch of homemakers that, maybe help somebody. And in many states, there's very little funding for this. Washington and Minnesota have really been the national leaders in helping to organize training and health and retirement benefits, which really has helped to stabilize the caregiving workforce for our Medicaid patients. But I will say that our average caregiver earns well less than $40,000 a year, and and they are not single. They have, families of 4 and 5 members. So it is a pretty low income group. It is predominantly women, predominantly older women. We want to try and find a way for this to help become more of a career ladder. You start out as a home health care aide, maybe you eventually become an employee at a long-term care facility, or maybe you become a registered nurse or somewhere along that ladder. We're trying to build that ladder, but it's going to take time.
I don't know if I should maybe help move us to the last part. I know you have only about probably 10 minutes before we turn it back to the staff to kind of close this out. But I know we wanted a little bit of discussion in light of this. We've heard quite a few different kind of presentations, and maybe we can have the next slide up because we do want to hear, I believe, from the board members on a number of questions. But we've heard from between Ken and Dave today, talking a bit, rounding us out on a kind of long day of discussions about the impacts of this new bill, whether it be on the exchanges, the Medicaid program, occupational health, home health. I mean, there's so many aspects that this bill is going to touch. And as I said, it's almost a 1,000-page bill, and there's a lot of content in there. And I think today all of our presenters did such a great job giving us a real sense of the broad impact this is going to have across settings, populations, geographies. So I guess, we want to hear what are in front of mind for you and the groups that you represent, which we've talked a little bit about. So, and what additional questions are people still wanting to know more about, especially as it relates to helping us understand cost growth. I see Jody's hands up.
Jody?
Yeah, so just a couple things. First, I do think I'm really worried about work requirements, and I would love for us to help the state figure out their approach, because this is something that's being left to the states to define. The reason this is so impactful, I think, is that as we find people unable to maintain their insurance coverage, that we're going to have worsening of health status and more ED visits and all of this, right? Kind of, we're going to be way downstream of the healthcare issues instead of being in a more preventive state of mind. And that is not going to be healthy for cost growth. I think the other thing is that with the doubling of redetermination for Medicaid recipients, that we know every time somebody goes through that, the odds are that some of them are not going to get all the way through all the hoops. And so again, thinking about the insurance loss of not only, end of subsidies, increase in premiums, and then these other efforts that are going to make the hoops more numerous, more narrow, and more complicated. A lack of coverage is a huge driver of cost growth. In the very short term, not so much, but very soon it starts really escalating. So I'm thinking about our role here. I think we need to think about how do we anticipate and mitigate the impacts of these things that we've all seen this bad movie about before. And so I don't know exactly what that means for this board, but I think those are two of the most important things. Again, the work requirements and how that is going to impede and discourage people from insurance. And the second is all the other things that are going to make it hard for people to hang on to the insurance they have, because all of that is going to result in much more costly and much more difficult to solve issues that will drive growth of costs.
I'll add to that, I certainly see that this does not just affect people's access to insurance coverage, but it affects a lot of the other social determinants of health that people rely on, having food security, access to education, things like that, that kind of came under this bill. And I know this board has talked about wanting to understand how the other factors of people's lives impact cost growth. So I would love to kind of revisit that topic again as part of thinking about cost growth. And if others on the committee have thoughts on the cost board's role for addressing impacts to Washingtonians in light of these discussions we've had today. See Margaret's hand.
Yeah, I'm thinking particularly about the role of the cost board and our objective to try to bring down the rate of growth in cost. And it seems like what we're facing is going to be very chaotic. And it's hard to figure out how we're going to hold the healthcare system accountable for reining in their costs when there's likely to be enormous cost shifting going on because of the loss of coverage and the loss of funding. And hospitals and the physicians and others are going to be really struggling to cope with this and try to figure out how to survive. So it brings up a lot of questions in my mind about how we can proceed. We don't want to go on parallel tracks and say, okay, we know all this is going on over here, but our role is to have you bring down the rate of inflation to a lower number. It just seems like a very odd thing.
Yeah, that's a great point, Margaret. And I am reflecting even on the slides I presented earlier today about our hospital discussion and posing to our advisory boards on the strategies for hospital spending because and you know to date we've spent a lot of time on hospital spending because that's really where the data have been probably most robust, where we can really break things down quite well, and it's a large part of our overall spending bucket. But to your point, Margaret, we also know that there's a lot of action taking, or at least preparation that's taking place across probably many of our major medical systems in preparation for the future to come that's so unclear still right now. I mean, we have more clarity now that the bill's been signed, but I think what the implications are of it, how people will react, how patients will react, how individuals will react in this market is hard to predict. Understanding what might be stopped in courts, I think, or other bills is also hard to predict. So I would love to know kind of people's thoughts on kind of how how we can keep having a discussion on like how can we help prioritize and figure out how to keep people accountable in health spending discussions in light of this. I don't know, Margaret, if you're trying to say something, I see your box lit up, but I don't hear something.
No.
There's a comment here as well.
I think I'm done.
Eileen has a comment in the room.
Well, I'll just play my role as Pollyanna. Yes, everybody knows that's how I am. But what I would say is when God gives you lemons, make lemonade. And I think we just have to try and change into the mindset of, okay, this is a disaster. We're moving back 20 years, but where were we 20 years ago? What did we do? The basic health plan. I mean, there are other things. So I guess I just am challenging the board that we shouldn't give up what our goal is to bring down the cost of healthcare. But we want to do that by keeping people healthy and insured. So we should, think about what other things we could do, and I will say from my years in the legislature, it's usually you can get things done when there's a crisis. That's when, we all have to pull together and figure out how we're going to move forward. So again, that's our challenge, I guess I would say.
That's a great point. And I agree. I mean, right now it seems like more than ever, we need to keep health care affordable because a lot of people are probably going to be struggling, especially those in the low income categories. But at the same time, the cost shifting that was discussed, and I appreciated, I think it was Jane who talked a little bit earlier about monitoring kind of what is kind of happening in the insurance side as things may be shifted around. As people get fall into uninsurance, they find themselves not going to healthcare much later, and then they become unhealthier, and then this creates quite a strain on the health system as people show up in emergency rooms more often, or they come with more severe conditions because they didn't do any preventive care earlier that could have been afforded. So that puts a strain on the hospitals, and then that results in higher costs that then translates to higher premiums, and it's all a circle.
I would agree. It feels chaotic, but I would say, Eileen, I appreciate your reference to 20 years ago. I don't think it's going to be as bad as 20 years ago. It hasn't completely unraveled all of the Affordable Care Act coverage that we have put in place over the last 11 or so years. We have really made tremendous strides with an expansion of coverage since that act was passed. And we don't have the individual market that's collapsed as we had in, 20 years ago. So we still have some really good foundational pieces to build on and make sure that we can mitigate some of this damage. Like Jody mentioned, the workforce requirements, we have opportunities to design systems that we think will be more friendly or manageable for our enrollees. And certainly our teams are working on that now. So I don't want to leave a doom and gloom, the world has collapsed feeling to this discussion. I think it has brought new challenges, new opportunities for us to think about where we lean in together. But we have a lot of really good foundational pieces that we will retain and continue to build on as well. Jane has a comment, I see.
So, I mean, just one thought. One of the things that we didn't have 20 years ago was the all payer claims database. And it really does give us and we've now got data going back to 2016 in the APCD. So I do think it is worthwhile giving some thought to what things can we sort of monitor in real time via quick looks at the APCD. So, for example, Margaret's comment about cost shifting, right? So can we look, admittedly, we don't have self-funded claims, but we have fully insured claims. And frequently the carriers are negotiating one contract for both their fully insured and self-funded books of business. So can we take like snapshots of looking at, what's being paid for a subset of inpatient services or outpatient services, just to really try to get a sense of whether we really are seeing a big uptick in rates that could be a result of the loss of revenues that providers are experiencing on the other side. And then also looking at Medicaid to really get a sense of, how much of a hit there really is in terms of Washington state specific data. So.
Great. All right. I think we have had a really good, robust discussion today. I appreciate the entire board leaning in, engaging actively. It's been great to have a comprehensive discussion today. I know there are more opportunities for that as well, but I think we should probably wrap up a little bit. I know that Ross had some announcements he wanted to share.
Thank you so much, Michelle, and thank you to all the cost board members. I know we asked a lot of all of you, and just so grateful and appreciative for everyone's work in putting together slides and bringing their own perspectives. I just wanted to provide a quick update related to meeting materials. I was hoping that they would be posted by the end of the meeting, but got notification that they will be available tomorrow. And so that would be the WISMA public comment, HB's presentation, and the L&I presentation by Dr. Dave. I will circulate Gov delivery through the cost board before the end of the week that will have links to all meeting materials, including those 3 documents that were not in this packet, the WISMA public comment, HBE presentation, and L&I presentation, as well as a link to the meeting recording. Please reach out if you need anything additional or you have any additional thoughts about things the cost board can be doing to better understand federal impacts or any other work that would be helpful for you to understand that. Once again, thank you for everyone's participation today, and I'll give it back to Michelle.
Thank you, Ross. I think we also wanted to share that we have some changes coming on the next meeting. I believe we are in process of trying to move the September meeting to October 23rd and switch the meeting we had for the committees reserved for that date. We need to have some scheduling conflicts we are trying to work around. So looking potentially at October 23rd. The team needs to confirm that formally, but that is what we are working towards at the moment, with potential committees on September 25th.
Yes, flipping our currently scheduled cost board meeting on September 25th with the advisory committee, and moving that cost board meeting to the October 23rd, where the advisory committee is currently. So switching those 2 dates, and I can provide an update in that on the Gov delivery announcement as well.
So I think that will help us plan into the future and get ready for our continuing policy discussions. The legislative report that is due annually. I believe the team will have a first draft for us in that October meeting, and get ready for our public hearing on the benchmark performance in the November meeting. So we have a couple of pieces teed up to wrap up the year and get ready for the legislative session. So the cycle will continue and the data deliverables will be coming on some of those products as well. So thank you all for your generous time with us today. I know it's been a long meeting. I think it was a really robust discussion and appreciate your engagement and your attention. If you have additional thoughts, as Ross said, please don't hesitate to let us know. And with that, we will adjourn the meeting.
Thank you all.